Guys, welcome back to the channel. Today we discuss the dawn trial, thrombectomy in 6 to 24 hours after the stroke with a mismatch between the deficit and infarct. Please hit the bell icon and please subscribe to my channel. My name is Dr. Bhushan Borade, MBBS CTCCM. You can follow me on Instagram, MediTalk by Dr. Bhushan, and YouTube as the same channel, MediTalk by Dr. Bhushan.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accept no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question: in a patient who are in a 6 to 24 hours post-acute stroke have a mismatch between the clinical deficit and infarct, does the thrombectomy plus standard medical care compared to the standard medical care alone improve the functional outcomes at 90 days? Background for these studies: previous randomized trial have demonstrated that the thrombectomy is of benefit when performed within 6 hours of stroke onset. There is a limited information on the effect of thrombectomy after 6 hours. Patients who are ischemic brain tissue that has not been infarcted may benefit from the reperfusion. This patient can be identified by the clinical deficit that is disproportionately severe relative to volume of infarcted tissue on imaging studies. Design for this study: this is a randomized control trial, web-based randomization software, 1:1 randomization stratified according to the age, mismatch criteria, time from onset, occlusion site. Unblinded open label trial. Allocation consignment maintained during the randomization. Primary outcome assessed by blinded structure. Interviews in a person, number 163 and telephone 43. Second primary outcome added the changes from the secondary outcome at 30 months with list of the still trial blinded following request from the Food and Drug Administration. Perfusion diffusion imaging measuring the impact and ischemic size will calculate the rapid software. Intention to treat analysis. Adapted trial design. Allow sample size 150 to 500 patient. Pre-specified end or point enrichment modification, inclusion exclusion criteria. Trial stop following the first planned interim analysis. Therefore no modification, inclusion exclusion criteria have been performed. Funded by the Stryker Neuroscience, who supplied the thrombectomy device, performed data analysis over the site from the independent statistician. Setting for this study: 26 centers were performed at least 40 thrombectomy cases annually in USA, Canada, Europe, Australia. 206 patients enrolled, 107 intermission, 99 control. Duration for this study: September 2014 to Feb 2017. Population inclusion criteria: age more than 18 years, acute ischemic stroke, failed IV tenecteplase or treatment with a IV tenecteplase contraindicated, last known to be normal 6 to 24 hours previously, baseline modified ranking score 0 or 1, occlusion intracranial internal carotid artery or first segment of middle cerebral artery, M1 MCA or ICA. Mismatch between the severity, clinical deficit or infarct volume. Group A, more than 80 years, NIHS score 10 plus, infarct less than 21 ml. B group, age less than 80, NIHS score plus 10, infarct volume less than 31. Group C, age less than 80, NIHS score 20 plus, infarct volume 31 to 51. Exclusion criteria: clinical, pregnancy, septic embolia, recent severe head injury or major hemorrhage. Prior to thrombectomy, use seizure at stroke onset and preclude accurate the diagnosis and NHS assessment. Sustained hypertension that is not reduced with medication. Systolic BP more than 185 or diastolic more than 110. Laboratory: blood glucose less than 50 ml mg per DL, hemoglobin less than 7, platelet less than 50, sodium less than 130, potassium less than 3 or equal more than 6, renal failure, creatinine more than 3 unless the pre-existing hemodialysis, INR more than 3, PTT more than 3 3 times of normal, receive factor of 10 factor within a 24 to 48 hours unless with a normal APTT, imaging, intracranial hemorrhage, infarct 1/3 MC territory at a baseline, cerebral vasculitis, flow limiting carotid dissection, high grade stenosis, complete cervical carotid occlusion requiring stenting at a time of index procedure, intracranial stenting in treatment area from a pre-existing intervention, tortuous vessel, multiple oscular occlusion, tumor, significant mass effect or midline shift. This is the exclusion criteria. 206 patients were enrolled, 107 randomized to intervention group and 99 randomized control group. Comparing baseline characteristics between the intervention and control groups, no significant difference in age, male sex, diabetes mellitus, prior ischemic stroke, median NIHSS, infarct volume, occlusion site, type of stroke, time from the last well to randomization, significant difference in rates, atrial fibrillation, treatment with IV alteplase, wake-up stroke. Intervention, mechanical thrombectomy with a trio device plus standard medical therapy, use of rescue device not permitted, stenting of cervical IC at the time of thrombectomy not permitted, thrombectomy performed in 107 to 1075 patient. 3 of these patients underwent treatment with alternative endovascular reperfusion device after initial treatment with a trio device failed. BP control was in post-thrombectomy patient is the systolic BP maintained no less than 140 to prevent ICH. Control group in standard medical therapy. Management common to both groups. All patients receive CT perfusion or MRI with diffusion imaging. Enrolled patient admitted to stroke unit and intensive care unit. Standard medical therapy according to regions national guidelines. USA AHA 2017, UA Europe ESO 2009, Australia Clinical Guideline for Acute Stroke 2007, Canadian Acute Stroke BPG 2015, aspirin more than 81 mg, DVT prophylaxis and compressive post-stroke rehabilitation standard. Outcome, primary outcome significantly improved in thrombectomy group. Comparing with the thrombectomy versus control group, utility weighted MRSA for disability at 90 days 5.5 versus 3.4, absolute difference 2.1, adjusted difference 2, posterior probability of superiority more than 0.9, functional independence at 90 days 49 versus 30, absolute indifference 36, adjusted 33, fragility index of 22 patient NNT 3. Modified ranking scale versus utility weighted modified ranking scale, MRSA value. You can read this and you can take a screenshot. Secondary outcome, all significantly better outcomes in thrombectomy group. Early therapeutic response, vessel recanalization at 24 hours, change from the baseline infarct volume at 24 hours, infarct volume at 24 hours. Safety outcome, no significant difference in stroke related mortality at 90 days, death from any cause of 90 days, symptomatic ICH intracranial hemorrhage at 24 hours, neurological deterioration at 24 hours, significantly reducing thrombectomy group. Thrombectomy related complication occur in 7%, distal embolization, intra-arterial dissection, arterial perforation, excess site of complication leading to intervention. Subgroup analysis, first primary outcome, no evidence in heterogeneity, treatment effect, divided based on mismatch group, age, baseline, NIH score, type of stroke, time from the last well to randomization. Strength for this study, the effective randomization allocation, co-primary endpoints are clinically relevant even if you use a single primary endpoint. Use of dichotomous MRSA, UA MRSA removes some of the ambiguity associated traditional MRS. Blinding of assessor of primary outcome, multi-center. Weaknesses, use of co-primary outcome comes with a typical caution. Industry sponsor using a single device. Imaging modality resources are unique and may not be available to all clinicians. Took place in those with NIHs more than 10 may secure fewer and treatment effect of less severe stroke were not included in this trial. Most patients had infarct volume less than 10 ml, which may also skew toward those anatomical less severe stroke. The control group had a higher rate of tinnitus treatment, while the experimental group had a higher rates of atrial fibrillation, wake-up stroke. Both groups of patients receive intensive monitoring and post-stroke rehabilitation management, which may be superior to the which can be provided at some center. Trial closed early, subgroup thus underpowered. Thus, control group in this study has a worse outcome than control in prior studies. Utility-weighted MRSA relatively new, and there is much variability in individual patient response, and data may be limited the power of trial. UWMRSA weighted has been shown to more power to the dichotomous MRS used in second primary outcome here, but be less power than the ordinal MRS used in prior trials. Author conclusions: in patients with the intracranial internal carotid artery or proximal MCA stroke who had mismatched clinical symptoms versus infarct volume and who were last seen a normal 6 to 24 hours prior, thrombectomy is superior with regard to functional independence and disability at 90 days. Bottom line, or may I suggest the inpatient who were last seen normal at 20 between the 6 and 24 hours who have infarct and either intracranial internal carotid artery or proximal MCA endovascular therapy with a trio device produces better functional outcomes at 90 days. This is however industry-sponsored study that is using advanced imaging techniques, comprehensive stroke care that may be available to a small center. Finally, this patient had relatively small infarct volume, average less than 10, as opposed to clinical symptoms NIHS 10 plus has not been validated in smaller clinical stroke or those who are larger infarct. Additional study with a variety of devices across broader group stroke are needed to validate this study. Dawn versus diffuse study. Key inclusion population difference. Enrollment NIHS more than 10, diffuse less more than 6, age more than 18, diffuse 18 to 19, infarct size 51, diffuse less than 70. Imaging inclusion: mismatch between the severity clinical deficit and infarct, estimate to the numera ratio. Time of inclusion: post last seen normal 6 to 24 hours and 6 to 16 hours. Actual AVG NIHS 17 and 16. Study closure: early met efficacy. Dawn versus diffuse. Key result differences: Dawn versus diffuse, endovascular group 107, control group 99, endovascular group 92 and control group 90. First primary outcome 90 days 0.5, 3.4, and diffuse 3 and 4. End co-primary outcome to 49%, 13%. Primary safety outcome at a 90-day mortality 1918 and diffuse 1426. You can take screenshot and read this diffuse versus Dawn trial. Thank you guys. Please subscribe to my channel, get a new study. You can subscribe, then I will make a new chapter, a new PPT for you. Thank you.